local expert on, I'm sorry? Oh, our very own local expert on cardiac CT. He's going to be educating us on where in our own clinical practices it might be appropriate to utilize this modality. Thanks very much, Shinbane. Dr. Shinbane, we appreciate your joining us.
Great, thank you. Can you hear me?
Yes.
Excellent, very good. So I thought today I'd go over cardiovascular computed tomographic applications. Again, a lot related to internal medicine, but also some of the other things that some of the subspecialties and that we are using it for. So basically the goals of the lecture are to provide understanding of applications of CCTA, one for cardiovascular risk stratification, and we'll talk about calcium scoring. Second, diagnosis of obstructive coronary artery disease. And third, an area that's one of my areas of work, which is 3D virtual planning and facilitation of cardiovascular procedures. So first, we'll start with coronary artery calcium scoring. And this really, understanding the importance of it really relates back to understanding the pathophysiology of acute myocardial infarctions, particularly related to plaque rupture. So again, things that have been known for a very long time are that the majority of people destined to die suddenly will not have had a positive exercise test. The likely reason that they will die suddenly is that only a mild non-flow limiting coronary plaque will have been present before the sudden development of an occlusive thrombus. So non-obstructive plaque suddenly ruptures, every platelet in sight goes and forms a thrombus at that site. So again, the initial manifestation of coronary artery disease can be acute myocardial infarction or sudden cardiac death in up to 50% of patients, which allows us really to need to search for better tools for predicting risk and therefore initiating therapy such as statins. Again, data that goes back to autopsy data from the 1970s and 80s, again, with acute myocardial infarction, arterial segments with obstructive disease are often not the site of vessel occlusion in acute MI. Acute coronary occlusion occurs most frequently. At the site of mild to moderate stenoses in association with the process of plaque rupture. So studies of acute MI and sudden cardiac death have demonstrated that what we need to look at is plaque burden rather than the severity of stenoses as being the most important factor predicting future events. Again, the more plaque you have, the more chances you have of rupturing a plaque. These are our traditional risk factors. Again, it's taken us a good 70 years to figure them out. Diabetes, dyslipidemia, smoking, hypertension, obesity, physical inactivity, and again, the more vague family history, which is going to relate more to genetic factors. Again, these risk factors explain only about 1/2 to 2/3 of cardiac events. So again, they are not covering all of the potential risks to having an acute MI. So the question becomes, how can we therefore assess cardiovascular risk? And again, what we need to do is assess for the effect of all patient factors through quantification of atherosclerotic plaque burden. Again, it's taken us 70 years to figure out 5 factors. There are probably hundreds to thousands of factors that we may not ever fully identify. So the answer is to look at it from the other end and say, well, does this person form plaque, and do they form more plaque than their peers do? So when we talk about coronary calcium, really you need to think about it like an LDL or an HDL. Think of it as a number that confers risk. So the coronary artery calcium score is a number that provides assessment of cardiovascular risk. It is a marker of overall plaque burden rather than a comprehensive measure of plaque burden, as non-calcified plaque is not quantitated. If we could truly quantitate both calcified as well as non-calcified plaque, that would really be kind of the uber marker of risk. But really, we're just counting the calcified plaque, recognizing that behind this calcified plaque, there is non-calcified plaque on its way to becoming calcified. And the studies demonstrate that coronary artery calcium has independent and incremental prognostic significance beyond traditional risk factors. So this is one slice of a study. Again, the slices are taken throughout the heart. Here's our left main. Again, if all of the slices look like this would be a calcium score of 0. Again, this patient has calcification of the left main and LAD, and I'll show you how the calcium score is calculated. But one of the big divides in the road is the score 0 or higher than 0? And then the next big divide is we'll see, does the patient have a profoundly elevated calcium score, greater than 400 or greater than 1,000? So calcium score of 0, no detectable coronary artery calcium. The presence of atherosclerotic plaque is very unlikely. Highly unlikely is the presence of obstructive coronary disease. Again, it occurs in the majority of patients with angiographically normal coronary arteries and is consistent with a low risk of cardiovascular events over the next 2 to 5 years. We'll go into more detail of this a little later. On the other hand, extremely high calcium scores. This is a study done from Coronary Artery Calcium Consortium, retrospective study of 66,000 patients. In those with a score of greater than 1,000, the multivariable hazards ratio adjusted for conventional risk factors showed a 5-fold increase of cardiovascular disease, almost 7-fold increase of coronary artery disease, and a 3-fold increase of all-cause mortality compared to those with a calcium score of 0. So these two ends of the divide have great prognostic significance. Patients with a calcium score greater than 1,000 had more than double the mortality from cardiovascular disease and coronary heart disease compared to those that had a 400 to 999 scan. So let's take a hypothetical patient, a 46-year-old, no history of hypertension, no diabetes, no profound dyslipidemia, no smoking history, a vague positive family history of coronary artery disease. Is this patient at risk for cardiovascular events in the short or long term? Should this patient be on a statin? So again, the calcium score can help us further to answer this question in a younger patient who's potentially looking at the need for a lifelong statin or not. So how do we calcify using coronary artery calcium risk stratification? Again, it's a non-contrast CT scan to identify coronary artery calcium. We quantify it, and there are 2 ways to do it. The older method is the Agatston score. On the slices, the area is multiplied by a density factor. There's also a volumetric score, which measures the volume of calcium, but not the density. They vary slightly. In the studies, the volumetric is more reproducible. The MESA study database, though, which has been around for a long time and keeps being added to, again, has traditionally used the Agatston score. So that's what we use in the calculations. So we then interpret it through the multi-ethnic study of atherosclerosis, MESA database, using the Agatston score. So here's an example, again, a CT scan, non-contrast taken throughout the chest, or throughout the cardiac volume. This is our left main into our LAD, and we'll just go through and look till we see calcium. This program lights up the calcium so it looks red. So here's calcium, and we circle it, and it starts to quantitate. And we come down further, and this is the right coronary artery, and we see that there's more calcium, and it quantitates it. More calcium in the right coronary artery, more here and here. And then ultimately, it gives us a score. So in this score, what we care about is the total. So the total Agatston score is 184. We then used the multi-ethnic study of atherosclerosis. Let's say this was a 46-year-old female. That would put that patient at the 99th percentile. It's like golf, you want a lower score. So this patient has more calcium than 99% of females of the same age. If this were a male, 46-year-old male would be at the 97th percentile. Now, the MESA study also takes in an ethnic component to it, and for a small number of ethnicities, there are only 4 that it lists in the database, it will give us a more specific score. But for this calcium, for all of the ethnicities included, it changed the percentile by 1 point from 96 to basically 98. So nothing of great significance. So what do we do with this score? Do we put this patient on a lifelong statin? Well, the guidelines have evolved over time, and they continue to evolve rapidly. This is from the 2018 AHA-ACC guideline. Again, in intermediate risk adults or selected borderline risk adults in whom a calcium score is measured for the purpose of making a treatment decision. If the calcium score is 0, it is reasonable to withhold statin therapy and reassess at 5 to 10 years, as long as certain high-risk conditions are absent: diabetes, family history of premature coronary disease, cigarette smoking. If the calcium score is 1 to 99, it is reasonable to initiate statin therapy for patients greater than 55 years of age. If the calcium score is greater than 100 or higher, or in the 75th percentile or higher, it is reasonable to initiate statin therapy. So again, it's a 2A guideline. So in this patient, there would be justification to do that. This is from the National Lipid Association. This is a little more recent guideline from 2021. Again, what is the appropriate use of calcium scoring for risk assessment? Again, for adults aged 40 to 75, LDL 70 to 189, 10-year ACSVD score of 5 to 19%, so kind of low to intermediate risk population. Calcium scoring can be useful to decide on the need for and intensity of preventative therapies. Again, for these same, for adults greater of 40 or greater, with a risk score of little lower of less than 5%, it's reasonable for those with a family history of ASCVD to decide on the need and intensity of preventative therapy. So again, with a little lower risk, you're more likely to use a statin if there is a family history. For adults with clinical ACSVD, calcium scoring is not recommended. So if somebody has overt coronary artery disease, you do not need to do the calcium score. Again, from the multi-ethnic study of atherosclerosis, when it comes to race, ethnicity, sex, and age considerations, again, racial and ethnic differences have been demonstrated in the prevalence of coronary artery calcium. However, for all groups, the calcium score is independently associated with events regardless of race or ethnicity. The relative score increases, or risk score increases proportionally with higher calcium scores. Similarly, for all races and ethnicities, for a given calcium score, the rate of cardiovascular disease and all-cause mortality were higher in Blacks and Hispanics compared to whites and Asians. And these are the 4 categories in this database. Calcium scoring may be used to selectively to risk stratify adults less than 40 to more aggressive therapy when calcium is identified. And in patients aged 76 to 80, calcium score may be selectively used to reclassify risk and aid in statin treatment. So there were kind of recommendations based on both younger as well as older age patients. So the two big divides in the road we said are calcium score of 0 and those greater than 1,000. So if the calcium score is 0, it's associated with highly favorable cardiovascular and non-cardiovascular prognosis. It's the strongest negative risk marker. And again, in the absence of other significant risk factors such as diabetes, smoking, history of premature disease, statin therapy in those with a score of 0 is associated with limited short to intermediate term risk reduction. The absolute risk reduction with statin therapy is proportional to the calcium score. So the higher the score goes, the greater impact you have. Again, in these adults age 40 to 75 with all the, without other known risk factors, with a score of 0, it is reasonable to defer statin initiation. In patients 76 to 80 in whom the decision about initiation of statin therapy is uncertain, again, with a calcium score of 0, there's a factor favoring avoidance of statin therapy. So again, concrete guidelines that you can use to make decisions. When it comes to high calcium scores, there are several factors. Additionally, the location of the calcium has some importance. Patients who have multivessel involvement or left main coronary calcium are at higher risk. So in adults with predominant left main calcium, multivessel coronary calcium, or a profoundly high calcium score, stress testing and invasive coronary arteriography in the absence of clinically relevant symptoms is not recommended. So even in these settings, you still decide on your assessment for obstructive disease based on symptoms. If the score is greater than 100, initiation of a statin is recommended. In adults with scores greater than 300 and especially greater than 1,000, it's reasonable to use a high intensity statin and additional LDL lowering agents to achieve a greater than 50% reduction in LDL. So again, from a practical standpoint, when you think about the concept of plaque rupture, when you think about the fact that we have very few risk factors, many that we don't know, we're looking at it from the opposite end saying, do these patients form plaque? What is the number on an absolute basis? And how do people compare to their risk peer group based on gender and age? So now we're going to move on to other applications. We're going to start with cardiovascular CT angiography. This is using CT as basically a non-invasive coronary angiogram. So what's the challenge? CT's been around since the 1970s. The challenge is that we're imaging the coronary vasculature despite cardiac motion. But basically, advances in spatial and temporal resolution, the film speed and shutter speed of the CT scanners allow for visualization of the coronary arteries despite cardiac motion. The acquisition occurs within seconds. Again, it requires iodinated contrast and radiation, with radiation doses going down significantly with newer scanners and dose modulation protocols. So this is what we get. This is a CT scan of a patient, again, acquisition time, 3 seconds, and these types of images can be made with the click of a button. Here we can see as we come around the left main, coming into the LAD in a diagonal. This is our right coronary artery coming down and around the back side of the heart. And then here is our circumflex coronary artery. So this is truly a non-invasive coronary angiogram. Again, we can look at the coronary arteries, but we can also look at them in the context of the myocardial segments that they feed. This is just showing the tools that we can use to look at the coronary artery. So here's our pulmonary artery, our aorta. Here we're seeing our LAD, our diagonals, our circumflex, our right, in the context of their myocardial segments, the anterior wall, the lateral wall, and the inferior posterior wall. We can then use specialized software to light up the coronary arteries and slowly make the myocardium more transparent to see our entire coronary artery tree. And now we can see our sinuses of Valsalva with our left main, our LAD, our circumflex, and our right coronary artery, and can evaluate the lumens of the entire cardiovascular tree. This is just looking at it from a basically a side view, and we're going to see our LAD wrapping around our RCA and ultimately our circumflex coronary artery, and just light them up and slowly peel away our cardiovascular structure. This is looking from the bottom of the heart, and we can light up our coronary arteries and then look at their coronary distribution. So this is our right coronary artery giving off the PDA, which demonstrates that it's a right dominant system, and our posterior lateral branches, again, showing that the right coronary artery feeds the inferior and posterior portions of the myocardium, as well as the right ventricle in a right dominant patient. So not only can we see the coronary arteries from the outside, but we can see them from the inside. And again, as opposed to an invasive cath, which just provides a luminogram, we can see the actual lumen of the coronary arteries, and we can see the walls of the coronary arteries. So this software identifies the coronary artery, straightens, follows it throughout its entire course, and then straightens it out like a pipe and cuts it so that we can see the lumen all the way through. This is a pristine coronary artery. Again, if all the coronary arteries look like this, this would be a calcium score of 0 with no identifiable calcified or non-calcified plaque. This patient would be extremely low risk of a cardiovascular event in the next 10 years. So these are patent coronary arteries with no evidence of obstructive disease and no evidence of calcified or non-calcified plaque. This is evidence of calcified plaque that we can see here. And again, this is actually a non-obstructive lesion, but this would be contributing to the calcium score. If you look on this side, you see that this is non-calcified plaque. Again, it's non-obstructive, but this non-calcified plaque can be vulnerable plaque and can rupture and cause events. That's why the calcium score of 0 is not a complete reassurance, because remember that we also have non-calcified plaque. Again, ultimately, if you had a score that takes into account all the calcium and can quantify this non-calcified plaque, you would have the ultimate risk stratifier. So again, this is using the same techniques that I showed you previously. And as we come down through these serial slices, we can see that we come down to a significant stenosis of a coronary artery. Again, in this scenario, this is a significant stenosis without evidence of calcified plaque here. This is just to show you that we can also visualize the coronary arteries, native as well as bypass grafts. This is a Lima graft. This is a graft, basically the Lima is isolated. It is still connected to the subclavian. All the branches are clipped off, and this is coming into a diagonal branch. These are saphenous vein grafts taken from the leg, and they're attached to the aorta and then down to the right coronary artery and to a circumflex branch of the coronary artery. So not only can we look at native arteries, but we can look at coronary artery bypass grafts. This is extremely important for surgical planning, particularly for redo coronary artery bypass grafts, which sometimes can run right across where the sternum is, and with a reduced sternotomy, you would end up cutting through them. So the guidelines for the use of CT angiography to look at the coronary arteries, again, is in continual evolution as the data increases. This is from the Society of Cardiovascular CT from 2021 expert consensus. Again, it has become a first-line test for evaluating patients with no known coronary artery disease and stable, typical or atypical chest pain or anginal equivalent. So this is a significant change from many years ago, using it as a first-line test in this strategy. It's a first-line test for evaluating patients with coronary anomalies. So if you have a patient who you think has or has anomalous coronary arteries, it's a first-line test. Again, it's a first-line test for prior CABG, particularly if graft patency or location of the lima is the primary objective of the study. It may be challenging to see the native coronary arteries because they have a lot of disease and a lot of calcium, but when your focus is primarily on the grafts, it's a first-line study. It's considered a reasonable test for evaluation of patients with a non-conclusive functional study to obtain more precision regarding diagnosis and prognosis. So when you have the patient with the equivocal stress ECG, stress echo, nuclear stress test, and your feeling is that it may be a false positive test, it's a reasonable study to do. If you really think that it's due to coronary disease, you're probably going to go on to an invasive study. Again, it's a reasonable test for evaluating coronary stents greater than 3 millimeters. For smaller stents, it can be challenging, and we usually try to avoid that. Again, for non-cardiac surgery in younger patients with low to intermediate probability of coronary artery disease. So if you're going to crack the chest open to repair an ASD and you have a 45-year-old low-risk patient, traditionally you would still do a coronary angiogram because you're opening the chest and doing a surgery on the heart. But again, in a lower risk patient, you can rule out the coronary artery disease with a CTA. Again, when you have a patient who is going to be at high risk for a coronary arteriogram, the patient who's dissected their aorta and their angiogram would be much higher risk, and you want to rush them off very quickly to the operating room, CT angiography would also be a reasonable test to consider. So when it comes to even invasive angiography, one of the challenges is, what do you do with the patient with the intermediate lesion? The patient who has something between 50 and 75 to 80%. Well, if you're in the cath lab, you can do FFR. You put a catheter down that measures velocity, and you can assess the fractional flow reserve to assess for significance. Now that can be done with CT virtually. So it's kind of like you're devising a new car and you want to assess its wind tunnel characteristics. You don't build the car and do that. You basically do a computational model and you run it on a computer to look at it. So what you can do is, with a standard CT scan, reconstruct the artery and basically computationally measure flow across the segment to see if it's significant. So again, the formula measures maximum blood flow in the presence of the stenosis compared to maximal blood flow in the same normal blood flow in that same distribution. So therefore, the lower the number, the lower the percentage the more significance it has. So anything above 0.75, 75 to 80% is non-significant, and anything less than that would be significant. So you have your CT, you're not quite sure if this is significant or not. You do the FFR CT calculations, reconstruction and calculations, which currently can't be done on the workstation where you are, is a send out. And again, used to take weeks to do, then days, and now hours, but is not quite at the point where you can push a button and make it happen, but that will come in the future. So again, you can now assess the significance of a lesion as you could in the cath lab. So in the evaluation of stable coronary artery disease, CTA with FFR may be appropriate to evaluate functional significance of intermediate stenoses, increasing the specificity, positive predictive value, and diagnostic accuracy over regular CTA. So this, again, when it becomes more common practice, will revolutionize the ability to use CT, not just to completely rule out disease in patients with open patent arteries, but to assess patients with intermediate lesions. Again, this is the FFR CT. This was a profoundly significant lesion. And again, modeling was done to help plan the best stent size to fix this. So again, this is virtual pre-procedural planning that's done, and we'll come to that more in the next section. So again, when you look at the gold standard, which is invasive angiography with FFR, and compare it to fractional flow reserve CT, again, as a gold standard, and then also look at PET, regular CT, and PET CT, again, the sensitivity and specificity of the FFR CT is the closest thing to the invasive gold standard. So just briefly on CTA in the emergency room, this goes back to the last section we went through, which is doing it for the purposes of coronary angiography. So what can you do? You can have a patient comes in with chest pain, low to intermediate cardiovascular risk, normal EKG, 2 negative troponins, whisk them into the scanner, get a calcium score if you want to risk stratify them for statin, and do a CTA to make sure they don't have coronary disease, and send them out the door within 6 hours. Again, so it has been studied for many years as a rapid triage tool in low to intermediate risk patients with negative or equivocal troponins and no EKG changes presenting to the emergency room with chest pain. Again, we know that CTA has excellent negative predictive value. You do a study in a low to intermediate risk patient, see that the arteries are completely open with minimal or no plaque, and it has negative, excellent value in that regard. In studies that have been done over a long period of time, it has been shown that it's safe and efficient in excluding relevant coronary artery disease in the setting of ambiguous acute chest pain with low to intermediate risk. The problems are that in some studies, there's a lot of downstream testing that gets done. So if you have a study that's rock solid negative, then you're not going to do a lot more testing. But when you get a study that doesn't show an extremely tight lesion, but something more in the intermediate range, that can lead to a lot of downstream testing. Again, that's only happened in some of the studies. The other thing that's been a game changer is high sensitivity troponins. So now that we have rapid high sensitivity troponins, in comparison to CCTA, the CT scans did not identify more patients with significant coronary artery disease requiring revascularization, didn't shorten hospital stay, or allow for more direct discharges from the ER. So again, this is a rapidly moving target. I think there is a role for it in the emergency room, maybe as not as much of a role as we initially thought because of the high sensitivity troponins, but but still probably will have a role in a limited patient population. So let's move on to the last section of the talk. Again, this is something that we do here a lot for a lot of our advanced procedures. It's cardiovascular CT, basically looking at it as a 3D virtual patient avatar for electrophysiologic, interventional, and surgical procedure planning. So when you think about it, it's not just about the coronary arteries, it's about the fact that we can see the entire thorax. So what do we do is we virtualize the patient for procedural planning. The CT-derived virtual patient avatar allows for the planning of the optimal interventional and surgical approach in place of the actual patient and before hospitalization and the procedure. So the patient gets an outpatient CT scan. Again, the scan takes 3 seconds. The images can be processed to this form very quickly. And then while the patient's at home, we're planning the procedure virtually in a multidisciplinary format. So what are the goals of virtual procedure on surgical planning and facilitation? What we're trying to do is plan the approach for the most minimally invasive, time efficient, and materials efficient procedural approach. And again, this is by performance of the procedure or surgery using the virtual digitalized patient avatar, and also for quantifying the anatomy for the type, size, and sizing of procedural materials, catheters, valves, devices, grafts. All of these things can be quantified ahead of time. Again, the key to this approach and everything related to CT is maximal utilization of the DICOM image sets. So we're not going to just focus on the coronary arteries, but the entire thorax. So these techniques are important for percutaneous cardiac interventions, CT surgeries, and cardiac electrophysiology procedures. Again, listed to a whole host of these, and we will go through examples of them. So again, with cardiovascular CT, images acquired within seconds can be used to create this 3D avatar. And again, now that we have a little more exposure to it, we can see the three-dimensional relationships between the skeleton, between the thoracic large vessel vasculature, the heart, and the coronary small vessel vasculature, all in one 3D data cube. So we take the serial two-dimensional slices, we reconstruct them into one 3D reconstruction, and then we use it and use special editing software to basically navigate through it to answer the questions that we want to answer. So these techniques allow for virtual 3D views demonstrating multiple anatomic relationships. Again, the first is the visualization of the entire coronary arterial and cardiac venous vascular trees. If you look here, the lighter color are the coronary arteries coming off of the sinuses of Valsalva. And we can see here our right coronary artery, our LAD, and our circumflex. Remember that the blood then goes through the myocardium and comes back through a series of veins that mimic the coronary arteries and bring blood back to the great cardiac vein, to the coronary sinus, and to the right atrium. So we can visualize the entire vascular tree, important for many procedures. And remember, we use the coronary venous system to place biventricular leads. So a right atrial lead, a right ventricular lead are placed. If we want to pace the left ventricle, we're not going to stick a catheter inside it of the left ventricle. It's going to be snaked through the right atrium, from the right atrium to the coronary sinus, great cardiac vein, and down a vein on the lateral wall of the left ventricle. So you're actually pacing from the outside of the heart from the vein. So we can meticulously visualize all of these coronary tree structures with this same CT scan. So in addition to the relationship of the coronary and arteries and veins, we can then take the next step, which is looking at the relationship of the coronary arteries to the actual cardiac chambers and myocardium. So here we can see it all together, and we're slowly peeling it away to the coronary arteries. So coronary arteries and coronary veins, coronary vasculature, and cardiac structure. What's the next step? The next step is visualizing the relationship of cardiac structures to the thoracic structures. So putting them all together, and we'll start again in a second. First, we're going to see the skeletal structures, and then we're going to cut it back to the large vessel vasculature and the heart. We're going to peel it back to the heart and the coronary arteries, and then we're going to peel it back to the coronary arteries themselves. And again, this ability to see things that you couldn't see even with an open chest, the relationships of the structures to each other are what allow us to plan these procedures and to avoid certain approaches where certain structures could be in the way. So this is a virtual sternotomy, what the surgeons do every day. We're going to crack the chest. This is what we're going to see initially. We're going further back in the chest, the left atrium, back to our aorta one more time. They split the chest open. We're going to see the right ventricular structure first, left atrium, left ventricle, and back to the aorta. So what we're doing is we are giving them views in the context of what they're going to see if they go in for a standard sternotomy approach. Let's just look at this one more time. Sternotomy, the structures just behind right atrium, right ventricle, back to our left atrium, left ventricle, and then back to our aorta. So we're going to use these views to plan certain procedures. In addition to looking at everything from the outside, what we have is a 3D dimensional data cube. We can actually use special software not only to look at structures from the outside, but also from the inside. So here we are inside the left atrium, looking outward at the left atrial appendage ostium, the left upper pulmonary vein, and the left lower pulmonary vein. When people are doing AFib ablations, they're placing catheters through transeptal into the left atrium and cauterizing spots inside the left atrium. So knowing this 3D topography is extremely important. When people are doing Watchman devices, they're placing a device in the left atrial ostium. So understanding the size and three-dimensional characteristics as well as the topography around it are extremely important and something that we can do. So again, just like everything else, guidelines keep coming out. And again, for all of these things that I'm going to show you, there are now guidelines and appropriateness indications, again, for CT surgical, congenital heart failure, TAVR patients, left atrial appendage occlusion, atrial fibrillation, and cardiac resynchronization or biventricular pacing therapies. And basically, when you look at them, because it's such a multidisciplinary area, most of them are multidisciplinary guidelines. Again, for everything we do and for everything in this lecture, whenever we're talking about doing these studies, we're always assessing the risk-benefit ratio, recognizing that these studies they are radiation studies and they do require iodinated contrast. So let's look at some examples of creating the 3D patient avatar and using it for virtual procedure and surgical planning for complex clinical scenarios. Again, there are many scenarios where there are standard procedures and not a lot of decisions that need to be made in terms of changing the type of incision or the type of procedure done. But here we deal with a lot of very individual anatomy and very complex clinical scenarios, and this is where it comes more into play. Let's start with anomalous coronary arteries, and this is just an example of a patient with Al Kappa. This patient was born with a left main that doesn't come off the aorta, it comes off the pulmonary artery. This is something that would be very rare for somebody to live into childhood, let alone adulthood, and be really fairly asymptomatic. Again, this is a middle-aged patient with more recent symptomatology. The reason that this patient survived is they had excellent collateral flow. But what we're able to do is make the diagnosis and also plan the surgical procedure. So this is the thorax, the full study here. We can see our sternum, our aorta, our PA. And what we do is we slowly peel back. This is our right coronary artery coming off the aorta as it should. We have a lot of structures in the way. As the surgeons go in, they'll be in the way. Here's our pulmonary artery. Again, it's over the left main and the LAD. So we peel it back further. We still can't see well. We peel it back further. And what do we see? This left main never hits the aorta. This is the septal wall of the main pulmonary artery. And what we see is the left circulation is coming off the pulmonary artery. The reason this patient, again, is alive is that there's collaterals from the right coronary artery that are feeding this distribution. Then we peel everything away. So not only have we made a diagnosis, we have evidence as to why this patient has adaptive mechanisms that delayed symptoms to adulthood, but we know the exact three-dimensional position of where this artery plugs into the PA, so that what the surgeons need to do is take it off the pulmonary artery and reimplant it into the aorta. So let's look at this, and this is just more of a video view, and we're going to just slowly peel back. Here's our PA, which is covering here's our LAD. The right comes off normally, our LAD and our left main. We peel back further, and we still, hard for us to see, it almost looks like it's coming off normally. Peel it back further, and now we have our diagnosis, and the surgeons know what type of approach they're going to need, what's going to be in the way, and what they're going to see when they do this. Again, while the patient's still at home before they've even come into the hospital to have the procedure done. And we can also get perspectives that they'd never be able to get in the operating room to get this three-dimensional analysis. Let's look at another one. This is a patient with adult complex congenital heart disease. This patient has an extremely rare syndrome where there's two superior vena cava, one on the right, one on the left. The left superior vena cava actually comes directly, plugs itself directly into the left atrium. There is then blood flow that goes through a large coronary sinus atrial septal defect to the right atrium, and blood flows back around through that channel. So profound, extremely rare anatomy. But what we have is we've taken this patient, and this is their actual heart. This is looking with the structures in place, and this is removing the skeletal structures, and we can see, and then we're going to turn the patient around so that we can see this SVC come in to the left atrium, and then we keep turning them around. We see this coronary sinus atrial septal defect coming into the right atrium. So again, the specifics aren't as important as the process, which is very unique, rare anatomy. Again, what was done was figuring out what structures needed to be cut, sutured, regrafted in to get this done. This is more commonly seen in children. And again, online, the Children's Hospital people, we all got together and they looked at the images too, and were helpful in helping to plan this very rare surgery to be done. The patient needed a special Dacron graft to connect the structures, and we were able to size the length as well as the size of the graft that was going to need to be used to make this happen. Just an example of valvular disease, one of the earlier uses kind of as the 3D patient avatar was for TAVR or pulmonary valve percutaneous replacement. Again, these percutaneous valves only come in certain sizes, so you basically need to know the exact coaxial dimensions at multiple levels of the aortic outflow tract. You also need to make sure that the pathway of the catheters that are large, that are used to place these through a retrograde aortic approach, that the pathway is clear. And if it's not, there are other ways to place it. If you, let's say the vasculature is so tortuous or so stenotic that you can't get up this way, actually in conjunction with the surgeons, a percutaneous approach and placing the valve through LV apical puncture, deploying it in place, and then the surgeons put a suture down here can be done. But again, all of this is done and planned, not with the patient on the table, but done ahead of time using three-dimensional images of the patient's actual anatomy that actually they'll look like a Netter diagram. This is a Melody valve. This is for approach to pulmonary valve replacement. Again, often done in patients who've had TET repair in childhood. The valve starts to leak. And again, going in to do another sternotomy procedure is a big deal. Again, the concern is that when you deploy this balloon, you could compress on the coronary arteries. So this patient who had a TET repair also, we found out when we did the CT, had anomalous coronary arteries. So if they put in one of these valves, the anomalous coronary arteries would have been right underneath the site and would have basically been squashed by this, the entire coronary circulation. So ahead of time, they knew that they could not use a Melody valve, that they would have to do an open procedure. And again, there were a lot of other factors. There was a lot of calcified wall right next to these coronary arteries that they had to kind of remove en bloc. So again, for this lecture, the importance is by having the patient's actual three-dimensional anatomy, using their CT as an avatar, a very risky procedure was avoided and a correct procedure was done, again, using a non-invasive study initially to guide it. Again, this is a patent ductus arteriosus. Again, these can be, they usually close, or everybody has it, and it closes with your first breath. These can be closed percutaneously with a coil. Some of them are too large and have to be closed surgically. And again, this CT allows us to see it in 3 dimensions. It allows us to coaxially look and measure the size at both ends, both the aortic and pulmonary artery end, and in the middle. It allows us to look at it from an endovascular approach and make these types of decisions. This is a patient who had hypertension diagnosed in his teenage years, just on a regular nurse visit at school. And that was about it. Had hypertension. In his 7th decade, started to have more symptomatology. And again, a diagnosis was made of coarctation of the aorta. So this is a profound coarc, too small to be taken care of with a percutaneous approach. But it's so tight here. And if you look, there are all these collateral vessels that come off to feed the lower body, basically, that also feed the spine. There is also, in addition to the coarc, another aneurysm just below it. So the decision had to be made as to the best approach and what should be done. Again, here's the rib. So the optimal rib space was chosen. There's both this coarc as well as this aneurysm, and it was decided that they would be kind of cut out on block here after clamping the aorta, and to put a Dacron graft here, which again was sized. So the CT scan was used to decide the incisional approach and materials. of, again, a very big and potentially risky surgery. And again, here's the final result. This is before and after, and we can see the Dacron graft in place. So initial decision for incision, lots of anatomy with this not previously diagnosed, and again, the final result. So we just have a few seconds or two or 3 minutes here. Just want to go through some EP things very quickly. Again, we can look at the heart from the outside as well as the inside. When AFib ablations are done, catheters are placed through a transeptal approach and long linear lesions are made to electrically isolate the pulmonary veins. So what can be done is you can take your CT scan, you can segment it out. You have your CT of your atrium. You then take a catheter and tap it around the atrium and it creates a shape. But this has all the electrical data. Then you have a computer merge these two maps and you can actually map on the patient's own individual anatomy to do your ablation. So it's merging of the CT with the EP lab mapping materials, which allows you then to map on the patient's own individual anatomy. All of these spheres represents radiofrequency lesions with isolation of the pulmonary veins and long linear lesions to create more organized pathways of conduction for electricity in the atrium. So using the CT and merging it kind of for real-time use in the EP lab. Just another example of complex congenital heart disease, and we don't have enough time to do it, but they had to cross a baffle that was created. Again, very complex anatomy to get to the atrium to do an ablation. And again, this non-invasively allowed them to know exactly how to navigate this atrial baffle. So you've all heard of Watchman now, and again, the Watchman is an atrial occlusion device to occlude the left atrial appendage. The left atrial appendage is profoundly complex. There's an orifice and then a body, oftentimes with multiple lobulations. This is an endocardial looking at the left atrial appendage ostium. Again, these devices are of a certain size and need to be placed in a certain landing area. And again, this gives the ability to choose the appropriate device and size it based on all of these features. And we can see how complex the left atrial appendage is and how well the CT can characterize it. Again, these are just a variety of different shapes of left atrial appendage and demonstrating how the CT can characterize the ostium, body, and lobulations of each of these approaches. Again, occasionally a left atrial appendage that can't be occluded from the inside can be taken out via a minimally invasive thoracotomy approach. And here we can see this is our left atrial appendage. And if you were to use such an approach, what incisional approach you would use to get to the left atrial appendage to basically do a left atrial minimally invasive appendectomy. And again, just briefly, the last slide relates to cardiac resynchronization therapy. So we have a coronary artery system, but we have a coronary venous system. Again, when you have a biventricular pacer or defibrillator, a lead's placed in the right atrium, in the right ventricle, but another lead is snaked into the right atrium, through the coronary sinus os, and then down a branch vein. So you're not pacing from inside the left ventricle, you're pacing from a vein on the outside of the left ventricle. And again, it allows you to pace both the left and right ventricle at the same time, which allows for them to activate the ventricles synchronously and can help guide these procedures. Some patients have a valve over the coronary sinus and you can't get in. We were able to diagnose this here. And again, in this patient, a catheter was brought in from below to push the door down on this valve, and then the coronary venous lead was placed in from above. So the CT allowed for finding an approach to get a lead when there was basically a door closing the valve here. So we've covered a lot of material. I think it's important just to recognize the power of the coronary calcium score in terms of risk stratification. Again, predominantly in middle-aged patients in low to intermediate risk who don't have a lot of other good reasons to be on a statin, who may have a family history of coronary artery disease, to help decide whether to put them on a lifelong statin and decide the intensity of therapy. It can be used to rule out coronary artery disease, and we went through some of the guideline criteria for that. It may have some application in the emergency room, but again, this may be more limited by the fact that the high sensitivity troponin evaluation is so good. And again, for us and in centers doing complex procedures, it's profoundly helpful as an avatar to help make diagnoses and then help plan and guide these procedures. All right, thank you. I'll take any questions anybody has.
Dr. Shinbane, that was an amazing demonstration of amazing technology. Thank you.
Thank
I know
you.
we had, excuse me, we had one question in the chat box, and that is, are we saying that CT angio should be replacing other stress tests, i.e. nuclear medicine in symptomatic patients?
So that information is changing very rapidly. And the guidelines, if you look at the last thing that I showed you from, it's from 2021. So that is something that is in process, and there are some new guidelines, I think, coming out soon that will justify that. You know, I would say that that day is coming. We still use a lot of other tests. You know, my feeling is that in many of our patients, you know, a stress echo gives us a lot of great physiologic information with no radiation, as well as giving us intracardiac pressures, valve status, myocardial thickness, myocardial motion. I think that we do need to take patient age into account. Again, the millisievert range with these studies has gone down profoundly, but it is still radiation, and it's radiation to the chest. So I still feel that there is a place for all of the modalities. And again, in many scenarios, it's like, give me a scenario, give me all the patient details. Can they exercise or not? What's their age? What are their underlying risk factors? Do I think they're going to have a lot of calcium that's going to limit the CT? Do they have stents in place that may limit the ability to look at CT? So I think that if you really understand the strengths and limitations of all the different modalities and understand the specifics of all those factors related to your patient, that you can make those decisions. But I think, as opposed to the past, where some insurance companies in the past would only pay for CT if it was related to anomalous coronary arteries, I think that's going to change, where it's going to be another viable modality, which may be a first-line modality in certain circumstances. But again, we're still going to need to take into account the biggest factor being radiation, and especially in younger patients in that regard.
Are there any other questions? It sounds like, from what you described from at least a primary care provider standpoint, I feel like for those patients where we're on the fence about whether to initiate a statin or not, that intermediate risk, low risk crowd, but with factors like family history that aren't always included in the calculators, that might be the sweet spot for us as general internists.
Absolutely. And the flip side being, if somebody has known coronary disease, or their lipids are profoundly elevated, or they smoke and they have diabetes, and you have a justification for a moderate to high intensity statin, yeah, then you don't need to do the calcium score, because you have your treatment plan in case. So yeah, I think that it is helpful in those other situations where yeah, you're just not quite sure, and particularly where the patient, they have a beautiful lipid panel, but they have a really bad family history, a high risk family history in that regard. That I would think about it. And there are some data in those patients who you think may need a statin, but are still somewhat hesitant. There are data demonstrating that getting a calcium score, something that's truly quantifiable, showing them that calcium score will help make them more amenable to the statin and also more compliant with the therapy down the line. And actually, that's in one of the guidelines that I showed, that other uses in terms of patient acceptance and compliance, having obtained and seen the calcium score themselves. So.
Great. Any other questions? Final thoughts? Thank you so much, Dr. Shinbane.
Great. All right. Thank you very much.
Appreciate it. Have a great day, everybody.
Thank you. Take care.
Bye-bye.